There are every chance of serious side effects, including anaphylaxis. Live easy, or believe. May Allah, the Almighty, help us so that we can serve the nation with honesty, dignity, and courage. Thank you all.
Antibody, and it is included in the management of asthma in GINA guideline, the step management. This is the reality, but not used in all the cases. It should be just as mentioned by Dr. K.C. Ganguly, should be reserved for severe, persistent asthma, uncontrollable with high steroids, and those who are affordable. But for poor patients, we will not use that drug for. It is for the affordable. Everything is for the people, those who have a lot of money. But it is a scientific molecule, and it is included in the treatment of asthma. And it is true that there is nothing, there is no cure to asthma. It is true also for Amalejula. There is no cure for asthma. Asthma, have to just improve to control the symptom of asthma, to reduce the suffering of asthma, to reduce the exacerbation of asthma. And Dr. Jesse also, he mentioned a very good thing, that it is very costly and it is not affordable. It requires repeated visit to doctor's office, and it is an injectable molecule. So there are a lot of things in favor and against use of Amalejula. I am in favor of Amalejula, I think. It should be reserved for the affordable person. And both this figure, I think both of them, they win the battle. Thank you very much.
Professor Muhammad Mustafiz Rahman. Sir. Now, Deputy Chair, our Secretary General as by Association, Dr. Muhammad Saidul Islam. Thank you, sir.
Abdul Rahman, up to the dais, and Dr. Hafiz Rahman Mia as a reporter.
Our first speaker, Dr. Adnan Yusuf Chaudhary. His topic is severe acute asthma, a focus on ICU management and ventilator strategy. Now I request Dr. Adnan Yusuf Chaudhary come to the dais.
Severe acute asthma, a focus on ICU management and ventilator strategies. Bronchial asthma is a chronic disorder of the airways with significant morbidity and mortality. Around 300 million people in the world currently have asthma. According to first National Asthma Prevalence Study in 1989, about 7 million people in Bangladesh are suffering from asthma. The studies revealed that approximately 10% of the patients hospitalized with asthma needs ICU management, of whom 2% need intubation. Now, the pathophysiological consequences of severe asthma episodes. In severe asthma episodes, airway obstruction, respiratory muscle fatigue, and altered V2 relationship can lead to hypercapnia and hypoxic respiratory failure. Insufficient expiratory time results in airway trapping, dynamic hyperinflation (DHI), and expiratory alveolar pressure, referred to as IP, which alters lung mechanics by increasing work of breathing while simultaneously placing the diaphragm at a mechanically disadvantageous position. The increased workload placed on the respiratory muscle results in increased oxygen consumption and carbon dioxide production, setting up a vicious cycle. Now, the risk factors for labile asthma, risk factors for death from asthma. Labile asthma, there is high degree of variability in peak expiratory flow, blood eosinophilia, history of sudden severe exacerbations within hours, history of intubation for asthma, history of ICU admission for asthma, 2 or more hospital admission for asthma within first year, 3 or more emergency department visits for asthma in first year, use of more than 2 canisters per month of inhaled short-acting beta-2 agonists, and current use or recent withdrawal of oral corticosteroids. Now the criteria for admission in ICU: failure to reverse the severity after emergency management, apnea or near apnea, central cyanosis, mental status changes, depressed level of consciousness, a sustained respiratory rate more than 40 per minute, failure to correct hypoxemia, that is SaO2 less than 90% in adult, less than 94% in children. Carbon dioxide retention evidenced by ABCO analysis. Now the management of severe acute asthma in ICU setting. Oxygen inhalation, supplemental oxygen to maintain SaO2 more than 92%, beta-2 agonist and anticholinergic through nebulization. In case of intubated patient, may be given by MDI along the respiratory circuit or between a Y-piece and the endotracheal tube. Corticosteroids, methylprednisolone 125 mg IV state followed by 40 to 60 mg IV every 6 hours. Consider tapering dose after 36 to 48 hours depending on clinical response. Now the additional therapeutic considerations: antibiotic treatment justified if patient has fever, prudent sputum, or if there is evidence of pneumonia or bacterial sinusitis complicating the asthma exacerbations. Magnesium, IV magnesium 2 gram infused in 20 minutes. Inhaled magnesium may be added to inhaled bronchodilators. Methylxanthines, equivalent bronchodilator properties as beta-2 agonist, but with increased potential of toxicity. Now, epinephrine may be considered in patients who do not respond or unable to cooperate with intensive inhaled bronchodilator treatment. Dosing 0.5 mg of 1:1000 dilation given subcutaneously every 20 minutes times 3 if needed. Heliox. Use of helium-oxygen mixture is based on decreased density of heliox compared with air, resulting in more laminar than turbulent flow. Mixture composed of either 60% to 40% or 70% to 30% heliox. Data suggested improved delivery of aerosolized bronchodilator when given with heliox rather than oxygen. Now the non-invasive positive pressure ventilation. NIPPV can be given to patients with severe acute asthma who are alert, cooperative, able to protect their airways while tolerating a full face mask. Initial bilevel positive airway pressure setting, IPAP of 8 and EPAP of 5, and adjusted promptly to achieve patient's comfort and compliance and decreased work of breathing without exceeding IPAP of 15 and EPAP of 5. Aerophagia with subsequent vomiting and aspiration are potential complications of NIPPV, so patients should be closely monitored and kept in nothing but mouth status. Clinical improvement should be documented within 30 minutes of initiation of NIPPV. Lack of improvement should prompt the clinician to the need of intubation and mechanical ventilation. Now, mechanical ventilation. Indication of mechanical ventilation, AVT criteria: PSO2 45 mm mercury or more and rising, PaO2 less than 60 mm mercury and falling, pH 7.4 or less and falling, SaO2 less than 90% even after 40% oxygen inhalation. The aim of mechanical ventilation: ventilator strategy should concentrate on allowing adequate expiratory time to avoid dynamic hyperinflation and trauma. Mechanical ventilation with volume control ventilation is preferable. A lung protective and permissive hypercapnia should be employed. Now the initial ventilator setting in severe acute asthma. Mode: volume control, minute ventilation less than 10 liter.